So at this year's ASH, we heard a lot about combination studies, and we'll come to that. But there were 3 abstracts with venetoclax combination that I just want to focus on before we move on. One was the analysis of responses, but more importantly, duration of response and survival based on a mutational analysis. And as we know, the patient with nucleophosmin, IDH mutations, very high response rates, very long duration of remission. On the other hand, the TP53 mutant patients, 50 to 55% response rates, but very short remissions and a very short median survival of less than 6 months. We'll talk later in this program about some new options for those patients. And they showed that BCL2 family member expression did not correlate with response. The second very important thing is that 31 out of, I take that back, about 10% of patients on those phase 1 studies went on to allogeneic transplant. They weren't supposed to be fit for allotransplant when they went on the study, but they went on, and they showed very good overall survival following transplant. That's all I'll say about it. Basically, I think the message is if you get an older patient with AML in remission, let's not forget that the only curative option is allogeneic transplant and may give them something that cures the disease as opposed to a prolonged maintenance. And then the last thing I'll say, and it came from actually MD Anderson, was the most sobering. And that was, we are seeing relapses and refractory disease with venetoclax. And the median survival of those patients was less than 3 months. They could not be salvaged. And they often had high-risk mutations. And the importance of that is in preparation for what's coming this year, the survival data from the low-dose Ara-C and the azacitidine combination studies. And I think we have to be prepared for the fact that maybe the survival benefit that we're all expecting won't be as great as we think. The toxicity of the combination, but also the ability maybe to salvage an HMA failure better than with investigational therapies, IDH inhibitors, versus salvaging an HMA ven. And I think we're going to really need to think about, does that mean that this regimen doesn't have benefit? And I would argue, of course it has benefit. Very high remission rates, very quick. I think what we've heard here is that we need to really think about how we manage the toxicity.
Yeah, I was just going to make a, because, and I reviewed this abstract that Dr. Maiti presented a lot with our group, with Marina and all, and that was what we don't want to give that message, because we did that subsequent part of the oral, that abstract was to show that in the end, the survival was still higher with HMA ven than any other HMA combination. However, since you're receiving a more effective therapy up front, the clones and the diseases that is emerging after that is just horrible. And this is actually very similar to a paper that had been published by Christoph Rohlig using 3+7 sorafenib versus 3+7 in non-FLT3 mutated. And what they showed in that was that the RFS was significantly improved with 3+7 sorafenib, but when they relapsed, they fell off the cliff. So I think the goal here really is that we kind of need to really restructure our clinical trial infrastructure, because this is becoming the largest referral population to us, AZA, ven, failure, relapse, and find new drugs. If you have FLT3, IDH, those were the only ones we could salvage, but for everything else, we have to develop new therapies.